Well, good afternoon, everyone. We're very excited about our program for today and welcome. Thank you for joining us. My name is Barry Sarvet, and I'm a child psychiatrist and the medical director for McPAP. And this is our monthly clinical conversation session. And we're really excited about the topic today. It's really focused on substance use care for teenagers and young adults. And so I'm going to introduce our speakers and we'll get started shortly. But before I do, I want to cover some housekeeping points. First and foremost, today is a very special day for us. This is the first day after many years of doing this that we're able to offer CMEs. And we're doing that through the generosity of Mass General Hospital. And unfortunately, the CMEs are exclusively for physicians and nurse practitioners. And we also have audience members who come from other disciplines. And so we'll have to work on that over time. But this is something that you can get. And I want to just give you a little bit of instruction in terms of how to do that. And so you pretty much have to send a text through your cell phone to a number which is on the screen now. It's 857-214-2277. And you pretty much just put in the body of your text the code for this particular session is DEQPUV. And we'll put that in the chat as well. And when you send that in, you'll get a response from the system with a link to an evaluation form. And after the session, when you complete your evaluation form, you'll be awarded your CME credit and you'll get a certificate. And so we really appreciate the help from Mass General for making this possible. So as usual, we're recording these sessions. They will be available on the McPAP website at www.mcpap.com. And the slides will be available on the website as well under the tools and resources page. Our presenters will be fielding questions, and we really encourage questions because in the title, we call this clinical conversations, and we really want to have conversations with you guys to talk about the material. And so if you have a question or any kind of remark, you can use the chat function or the question box. You can also use the hand raising and you can read the question, or you can say in the chat that you would like to, ask your question, sort of verbally. And so those are the options, and we'll field some of them during the presentation if they're kind of relevant to what the speakers are talking about at the time, and we may save some of the questions for the end, but we will try to address all the questions. So let me introduce our speakers. We have two co-presenters today. It's Dr. Mimi Schezer, and it's also Maria Franco-Alden. And I'll tell you about both of them. So Dr. Schezer is a staff member at the ASAP program, which stands for the Adolescent Substance Use and Addiction Program at Boston Children's. And she's been there since February of 2009. Since 2014, she has consulted with the PPOC, or the Pediatric Practices of Children's, on their adolescent substance abuse curriculum for their behavioral health learning community. She's also become the unofficial expert for the drug testing program at ASAP. And she also participates in the ASAP primary care project as well. So she's very interested in, and she's been working on trying to optimize the use of telehealth for providing substance use disorder treatment and to improve the safety net for adolescents who are high risk that are treated within this program. Maria Franco-Alden is a licensed independent clinical social worker And she is also a member of the staff at the ASAP program, and she particularly works in our MCPAP arm of the ASAP program. Maria is a graduate of Boston University's MSW program, and she has been providing counseling and social work services to youth and adults throughout her career. She's worked in many different settings, including outpatient, inpatient, home-based outreach programs. She's been at Children's Hospital in Boston since 2009, at the Child Health Associates in Central Mass to provide substance use evaluation and treatment to adolescents in the primary care setting. So both Maria and Mimi, Dr. Schezer, are really looking forward to speaking with you today, and I think we're going to find their presentation to be really, really interesting. So I will just hand off to you guys and take it away.
Barry, one
Yes,
second. If you notice in the chat, it looks like our texting doesn't quite work yet. So please put the fact that you are on the call, text it into the chat, just your name, and so that we'll have a record of it and we'll coordinate it. I think they thought we began at 12 and they closed it at 12:15. We have to get them to close it at 12:30. So next time, but at least for this time, just chat put your name into the chat. Thanks.
Yeah, thanks a lot, John. I appreciate that. And so we'll hand over to Mimi and Maria, and we'll get their slides up and we'll proceed.
All right. Hello. I'm just going to share my screen. Sorry, I'm a little from the beginning. Okay. So I'm Maria Alden. I'm a clinician with the ASAP MCPAP virtual care program. And I work with Boston Children's, but I work with MCPAP. So I'm going to start off. So thank you for joining our presentation today. We are going to go over the following learning objectives. You'll be able to describe how to utilize virtual substance use counseling service available through MCPAP. You will be able to understand how you as the PCPs can collaborate with substance use clinicians to provide care to your patients. And then we are also going to explore clinical examples of patients receiving virtual care through the ASAP MCPAP program. So next slide. Okay. First off, what is the ASAP MCPAP counseling service? Our program is virtual substance use care provided to adolescents and young adults who are currently treated by providers affiliated with MCPAP in Massachusetts. These are patients who may be struggling with cannabis use or nicotine use and can be supported in the community without utilizing a higher level of care. The clinical social worker provides comprehensive substance use evaluation, individual substance use counseling, parent guidance sessions when clinically appropriate, and can connect families with referrals to higher levels of care when needed. We will also be offering virtual group therapy in the very near future, and I will go over this more later in the presentation. The second component of the team is the substance use provider consultants, whom you can contact through MCPAP. They are available to assist providers with guidance related to medications for substance use disorders, such as nicotine replacement therapy, and they can also support PCPs regarding ordering and interpreting clinical drug testing when appropriate. They are also available to assist providers with any general questions related to the treatment of patients with substance use disorders. You as the PCP are immensely valuable and an important member of the team when we provide substance use care, and we appreciate any insight and support and want to support you. As a reminder, like how you make a referral, you call your MCPAP regional team, you ask for the ASAP consultant. And then when you speak with a consultant, I mean, you can give them a presentation of the patient, but let them know that you are seeking virtual substance use counseling for your patient. So today I'm going to go over a variety of vignettes of different patients that I'm serving. And we're going to kind of talk about some of the interventions that we provide. And then Dr. Schezer will also kind of go over some of the medical piece. So first, I'm going to talk about Michael. Michael is a 16-year-old Caucasian male who was referred for substance use counseling by his PCP due to him wanting to stop using nicotine and marijuana. Michael reports that he started vaping nicotine about 2 years ago when he was in the 9th grade. Once he started, he states that he quickly started using it several times a day. Michael recalls that he would vape every 10 minutes while playing video games. And his parents wanted him to seek substance use counseling when Michael was suspended twice in a very short period of time due to vaping at his school. Michael expressed that it has been very challenging to stop using nicotine because he feels triggered at school since so many of his friends and classmates vape in the bathroom during the day. He also feels triggered at work because many of his coworkers are heavy smokers. Michael reports that he started vaping marijuana around 2 years ago. Until a few months ago, Michael was using marijuana several times a day and could not go more than 3 hours without smoking or vaping THC. Michael stopped using marijuana regularly because he had been using THC cartridges and reported feeling very strangely on them. He also reports that he had gotten sick from using a THC cartridge, which led to him stopping his use. He stated that it has been a struggle to stop using marijuana because it has been a way to cope when he is feeling sad. My work with Michael has been focusing on helping him manage his triggers and cravings. I have tried to help him increase awareness of what contributes to his use. He has noticed that when he has a lot of idle time, he feels increased anxiety. He feels that when he is focused on a task that he is less likely to use. Recently, he relapsed on nicotine, and he has shared that using nicotine helps him feel connected with his peers at school. As with many of my patients, Michael expresses a lot of ambivalence about his use, and I use motivational interviewing techniques to help him explore the pros and cons of his decisions related to his use. He also relapsed recently on marijuana, and he has shared how sometimes he feels that it helps him cope better. So a lot of the strategy with approach is, validating where he's feeling and just kind of trying to explore that. And it's obvious, a lot of times it changes every session, depending on the events going on in the patient's lives. And in our sessions, I meet Michael where he's at, while also sharing with him information about the neurobiology of addiction, and then helping him examine the risks associated with using. I mean, this could be looking at the risks to health. This could be looking at the risks related to getting in trouble, which tends to be a motivator for a lot of teens that I work with, but just looking at the whole picture. And then I also work with him to identify the role and purpose that marijuana serves him in his life. And we are exploring alternative coping strategies that he can use that are more healthy. Prior to starting counseling with me, Michael's PCP had started him on nicotine replacement therapy. He was started on a 7 milligram per 24 hours patch. And when I started working with Michael, he said that he found the patch helpful, but that he was getting a lot of cravings throughout the day. When he spoke with his PCP, he was also advised to use the nicotine gum and lozenges to manage his cravings. And Michael reported that he felt that the cravings were well managed by the gum while at school. I have also collaborated with his parents about their own observations of what's going on with Michael, about his use and their concerns. I then have communicated these concerns with his provider to encourage him the provider to reach out for support from the ASAP consultants related to NRT guidance or any other support. So next, Dr. Schizer is going to talk a little bit more about treatment strategies.
All right. Thank you, Maria. And that was such a great case to get us started with, because you had so many nuggets in there that really coincides with what we see in our patients. I want to start by thanking everyone for attending today's session and for giving us an hour during your lunchtime to learn about this topic. So Maria asked me to say a few words about nicotine replacement therapy. And it's really interesting. I'll just say that the landscape has changed dramatically over the last few years with the explosion of vaping, no pun intended. And I'll honestly say that if you asked me 8 to 10 years ago how comfortable I was with nicotine replacement therapy, I would have said, you know, my kids like the word meh, M-E-H. But over the past few years, we've found that it is really essential to offer kids who are vaping, who have at least some willingness to quit or cut back, to offer them this medication because it works. And without it, it's much, much harder to change your nicotine use. Next slide, Maria.
I'm trying to move it. I don't know why it's not letting me. Okay.
Huh.
Oh,
backwards.
it went backwards. I'm sorry. Okay. There we
All
go.
right. Thank you, Maria. Fantastic. So I think talking about screening is probably beyond the scope of this hour. We at ASAP, we're very fond of SBIRT, which is screening, brief intervention, referral to treatment. I would urge everyone in this audience to make sure that they have a protocol in place for screening your adolescent and young adult patients for their substance use. We've seen in numerous studies that if you don't use a screening tool and screen your patients in a systematic way, there's a lot that you'll miss. One of the things I really like for smoking cessation, vaping cessation in general, is this idea of the 5 A's. And this goes back decades for physicians to talk to patients about quitting smoking. And I find that it's very relevant, and it's just a nice way to remember what it is you're supposed to do. So ask about use. That's where the screening comes in. If you don't ask, you don't know whether it's a problem. Every patient that you discuss substance use should hear you say, as your physician, as your healthcare provider, I advise you to quit for the sake of your health. So even if this is a patient that you're doing more harm reduction and you're working with them to cut back, at least once during the visit, you should give them pure, unadulterated advice that they should quit. In your conversation with the patient, you want to see where they are. I love it when Maria used the phrase that she meets patients where they're at, because that's really critical when you're having these conversations. So where is the patient in terms of readiness to quit? If they're not ready to quit, are they willing to cut back? You know, you kind of start where they are. Certainly the best scenario would be if they're willing to have a quit attempt, and then you're going to help them, you're going to support their way through it. And I can't really say this enough times, these patients deserve follow-up. As you would think about for any other medical problem, if you're seeing them for this, this is not a one and done type of a problem. You'll want to see them. And in the case of nicotine replacement therapy, regularly to tweak the management. Next slide, Maria. All right, so generally I've already said that you want patients to hear you say that the best thing they can do for their health is not to use at all. When we're thinking about nicotine replacement therapy, really the two most important criteria are, A, is the patient having cravings for nicotine? You know, maybe they are trying to quit, but they're having recurrent cravings. That would be an indication for NRT. And then equally important would be, are they having symptoms of nicotine withdrawal? The story of nicotine use is it enters the brain very quickly. So patients who are using nicotine will feel what it is they're seeking very quickly, but then similarly, the effect wears off very quickly. And so anybody vaping or smoking, it's a cycle that repeats itself throughout the day of feeling better and then feeling withdrawal. And so patients kind of treat that cycle by continuing to use. So it's important to be familiar with the symptoms of withdrawal. Typically what I hear from our patients, headaches, irritability, anxiety, depression, appetite changes, fatigue. It usually is a cluster of symptoms and patients just don't feel well. And even patients who want to quit will find that they continue using really to kind of self-medicate these withdrawal symptoms, if you will. So on a separate note, we have referred a lot of patients over time to the vaping clinic at Boston Children's. It's a really good resource. The big news story before COVID was EVALI, which is e-cigarette or vaping associated lung injury. When you're talking to patients about their vaping, it's very important that you do a screen. Have they noticed changes in their respiratory health? You know, you really want to ask about exercise intolerance, chronic cough, shortness of breath, or any other respiratory symptoms. And if you're hearing something you don't like, meaning there is something there, then the best thing to do would be to refer them to the vaping clinic at Children's. And certainly we've referred many a patient over the years to that program. Counseling, Maria, thank you so much for doing what you do. This is not something that you can treat just with medication. I think the combination of medication support and counseling is really what you want to offer these patients. There are a lot of support lines out there. There's teensmokefree.gov, 1-800-QUIT-NOW. There's a quit vaping app that many of my patients have used. You know, this is a smartphone generation. So anything that you can offer them for ancillary/tech support will be very helpful. If you're starting nicotine replacement therapy, you know, for these patients, you really are asking them to stop vaping. This is not something, we call it double dipping, that they're vaping and they're also using this medication. So for someone to start wearing the patch, start using the lozenge, your goal is that for whatever period of time they're willing, they try quitting. Maria, next slide. All right, so the underpinning of nicotine replacement therapy is that you are actually giving them nicotine in a controlled fashion, and so that you are, you know, treating the withdrawal symptoms and the cravings. And so you want to think about this for any patient. I would say anyone who's vaping daily should be a candidate, someone who's troubled by withdrawal symptoms or cravings. And the other niche you want to think about is if you have a patient, you know, this happens to us, if we have a patient who's psychiatrically hospitalized or hospitalized for another reason when they won't be able to use nicotine, that would be another time to suggest NRT support. Next slide, Maria. So what you want to do, and I love Maria's example and the PCP's approach, is you want to use a combination of long-acting nicotine replacement, which is the patch, with the short-acting, which is oral. So we use some combination of the patch with the gum or the lozenge. Those are really equivalent. Generally, there is a nicotine spray and a nicotine inhaler. We don't use those for adolescents because, to be honest, it kind of mimics the effect of using a vaping device. So it's not helping us as much as we should. Generally, these are very well tolerated. Next slide, Maria. So as I mentioned, the best way to do this is combination therapy using the nicotine patch for your long-acting nicotine replacement, and then supplementing it exactly as the PCP did in Maria's example with the short-acting oral forms. Thank you, Maria. Next slide. So again, I've gotten very comfortable talking to patients about using the patch. Generally, the instructions are to put on a new patch every morning as part of the morning routine. It's important to warn your patients to use a different site. If you're putting it on the same site day after day, likely the skin will get pretty angry and then no longer tolerate it. I generally advise my patients to take it off at night. It has been reported that patients who wear nicotine replacement at night to get vivid and disturbing dreams. So most of the time you will want to advise your patient to take it off. I think the only exception is someone who wakes up with such severe cravings or withdrawal that they really need the bolus overnight. Next slide, Maria. So life is a little tricky with vaping. You know, when we were talking about combustible cigarettes, I should take a step back. So the patch comes in 3 different strengths: 7 milligram per 24 hours, 14 milligram, or 21 milligram. When we were talking to patients who are using cigarettes, patients generally know how many cigarettes they smoke a day, and it was easy to figure out what to start with. So for patients smoking more than half a pack or 10 cigarettes a day, we would start with the highest concentration, which is 21 milligrams. Patients who are coming in below that would start with 14 milligrams. And then the idea is that you taper them off the patch. So in that first example, if you start someone at the highest strength, 21 milligrams, they wear the patch daily for 6 weeks. Then they step down to the 14 milligram for 2 weeks, and then they step down to the 7 milligram. Obviously, if you're starting at a lower strength, you're looking at fewer weeks, but the idea is the same, that you start with one strength and then you taper. Next slide, Maria. So life is more complicated when patients are vaping. We had a honeymoon period when most everyone was using the Juul, because we know that someone who uses a Juul pod a day, you may know this, that a Juul pod is equivalent to the amount of nicotine in 1 pack of cigarettes. So we had a fairly straightforward conversion. Someone vaping a pod a day of a Juul would come in with a 21 milligram patch recommended. 14 milligrams would be for someone using 1/2 to 1 pod a day, and then a few hits a day would be 7 milligrams. I will say to you that we've lost that translation for patients who are vaping. A lot of people use disposable vapes these days, and it's not really clear exactly how much they're getting nicotine per day. So I often have a conversation with a patient. I think if their perception is that they're vaping all day, every day, you might want to start with the higher patch. I think in my program, if we're unsure, we usually go lower and then supplement with the oral. And then, as I said, follow up. If you follow up with a patient and let's say you started at 14 and they tell you in a week, it's just, I feel like it's not touching me, then you would bounce up to the 21 milligrams. Ideally, you're using the gum or the lozenge in combination with the patch, and then you're dosing it every 1 to 2 hours as needed. And this too is something that you will gradually decrease as they get farther out. Thank you, Maria. Next slide. So there is a technique for using the short-acting nicotine replacement therapy. This is true for both the gum and the lozenge. I always say to my patients, this is not Trident. In terms of using this gum, there's a chew and park method where they start chewing the gum and then they get this bitter flavor, which means the nicotine is being released, and then they park it, hence the term chew and park, because if they chew it too aggressively, they'll end up swallowing the nicotine, which will give them reflux or nausea and just make them not feel good. So there is a technique. Ideally, it would take about 30 minutes for them to get the full benefit of a piece of gum. So that's something that you can talk to your patients as well. And it's also explained on the website. The lozenge or the gum does come in 2 milligram or 4 milligram strengths. For most patients, I usually use the 2 milligram strength, unless you have a patient with an extremely heavy history of vaping. Sometimes you'll come across a patient who does not tolerate the patch. Patients with sensitivities, sensory types of sensitivities will say they don't want to wear a patch, in which case you really can do this just with the oral forms, and you can see a taper where you use it more frequently in the first 6 weeks and then you gradually cut back. So again, starting a patient, supporting a patient, and follow up is the most important. Next slide, Maria. So I'll only say a couple of words. We also have some experience with Varenicline, which you may know as Chantix or bupropion. I don't have a lot of experience prescribing these, but generally for patients who don't tolerate nicotine replacement therapy, this is something to think about. We know that Varenicline is the most effective therapy for adult smokers. It's available for use in adolescents 17 or older. I think you'll have these slides. And so this is the dosing. Generally, you like to start at 1 to 2 weeks before a quit date so that it starts to have an effect before the patient stops. We say that you can treat for 12 weeks, but the patient can stay on this longer if it's helping them. Maria, next slide. So there was a transient black box warning for Varenicline about suicidal ideation or other adverse neuropsychiatric events. That's been lifted, but you still want to follow your patients carefully for all the usual reasons. And patients with seizure disorders that is a known contraindication. Next slide, Maria. All right, this is my last smoking cessation slide. Butrin is a wonderful choice if you have a patient where you're worried about depression and vaping, because this is an antidepressant. We're not really sure how or why it works for smoking cessation, but it does. I've given you some information about dosing. And so again, definitely something to consider. As I mentioned, I don't have a lot of experience with these two agents. That might be this kind of thing that you would want to give us a call if you wanted to start. I know our psychiatrists have treated with these medications more than I have. All right, Maria, I'm going to stop there.
Okay. I'm just double checking the chat to see if there was any
Maria,
questions. Yes.
just to, if people didn't see it in the chat, it looks like you can now do the texting. So please, if you're on the call and want CME credits, text as it was noted in the chat.
And then the only question I see, because I don't want to check because I'm sharing my screen, so I realize I can't look without disrupting the presentation. John Kelly asked about if there was a vaping clinic in Western Mass. Do you know, Dr. Schezer, if there is?
A vaping clinic in Western Mass. That's a really good question. I think for the pulmonologists, I think it's only in the main hospital for now.
Okay. All right.
And some of their appointments are virtual, but they do have patients come in for pulmonary function tests, chest x-ray, possibly a chest CT scan. So that does have to be in person. Good question. Thank you.
Okay. All right. Okay, great. So I will move on to the next section, if I can move the screen. Okay. So the next patient we're going to talk about today that I'm working with is Samantha. Samantha is a 17-year-old Caucasian female who was referred for substance use counseling due to her parents' concerns about chronic THC and nicotine use. Samantha has a history of depression and a couple of prior psychiatric hospitalizations related to suicidal ideation. Samantha's parents have expressed concerns that she is using marijuana, particularly marijuana, excessively. And when they have attempted to address her use or confronted her, significant conflict has erupted. Lots of tension, lots of yelling, lots of her storming off. They feeling like they can't reach her. So, so this is a part where they're, you're working with individually and with parents. So my individual counseling with Samantha has focused on building rapport with her and offering her a space where she can comfortably share her feelings. Samantha has expressed that she doesn't like talking about her substance use because she feels bad about not wanting to stop. Through motivational interviewing, I have been able to explore Samantha's motivation for her marijuana use, and she has been able to identify that she believes it helps her manage her depression. She has shared that her suicidal ideation has significantly reduced since she started using cannabis regularly. Through my sessions, I often explore with Samantha the pros and cons of her use and encourage her to identify and explore healthier coping strategies that she has available to her, such as art and running. She's really into drawing and is really interested in a lot of art things, and was also on the track team. In addition to providing individual counseling, I've been providing parent guidance to her parents. Much of the work revolves around validating Samantha's parents' concerns while also encouraging them to increase their self-awareness about their responses to their behavior. A little background about Samantha's family. In her mom's family, there's a history of substance use in a lot of the mother's family members. And so mom has a lot of concerns, which are very relevant, that, Samantha is going to develop a significant substance use disorder over her lifetime. But, this can create a lot of tension. It's really tough for parents to feel compassionate when their child is using substances, and often affects the entire family system. I provide them with psychoeducation related to the neurobiology of addiction and reflect with them about how that impacts Samantha's behavior. At the same time, I also explore with parents strategies that they can use to help reduce their child's risk. In Samantha's situation, her parents expressed significant concern about Samantha driving because of her heavy cannabis use. Since Samantha is motivated to drive, we have determined that clinical drug testing could help motivate Samantha to reduce her use. I have discussed with her parents the options of measuring her quantitative THC levels in addition to the regular routine drug screen, since THC takes a lot longer to metabolize in the body. I've reached out to her PCP and discussed that option, and the PCP seeks guidance from our substance use consultants to order the lab and interpret the results. Measuring quantitative THC can be helpful because it measures the level versus simply saying just positive or negative. Her parents recognize that Samantha may not be able or ready to completely abstain from her use at this time. However, they want to see that she is able to develop better control and see a reduction in her levels over time. So now Dr. Schezer is going to talk about clinical drug testing and how you, the PCPs, can support your patients in these situations.
Thank you, Maria. So I think this is a really important tool for patients that you are following them for substance use or substance use disorders. And we are always available for a phone call to help you launch serial drug testing with your patients or to answer questions at any point about it. So I'm going to give you an introduction of how we use it in our program, because I'm really suggesting that you do it in a similar fashion. So we have a robust drug testing program. This is for patients with known substance use or substance use disorder. Typically, the way we do it, if we're going to drug test a patient, we recommend weekly random drug testing to monitor their progress. I think you can get a lot of information for a patient with active substance use if you're testing weekly. And then the random is If you do it too predictably, then the worst way to do it would be, for example, to drug test a patient every Friday. If there's a predictability to it, patients could easily learn how to use around the testing. And that's why we like random testing. To get the most bang for your buck, if you will, you want to combine the drug testing with some sort of contingency management approach, some sort of predetermined set of circumstances where the patient is complying with the testing, gets, we talk a lot about carrots and sticks, so gets a benefit for tests that are showing no or decreasing use, and then some built-in negative consequence if the use is continuing. Obviously, this is not hugely popular with adolescents. I think if you ask a patient about drug testing, they might initially refuse. And that's why Maria's talking about the work with parents is so important, that the way we do it is we usually figure out a way that the parent can use leverage so that the adolescent is motivated to agree, if you will. Next slide, Maria. So our program typically is 12 weeks. Certainly some patients will do it repeatedly, so that's not the be all and the end all. But I think if you do it for less than 3 months, you lose some of the utility. I think that's a really nice window. I've already mentioned the randomness. There are different ways to do the collection. I should say that we partner with Quest Diagnostics for our drug testing program. Historically, patients would only go to the lab to give a urine sample. Hours aren't great, and certainly for kids who are in school, maybe have an extracurricular activity after school, it can be very hard to get them to the lab. So what Quest allows us to do is the parent can take home cups and do a home collection. And I'd encourage you to consider this for your practice as well. And if the patient is voiding at home, we like to recommend supervised collection, because depending on what the stakes are, certainly kids might try to, quote, beat the system. And then we're going to talk about how we like to get the first morning void, which in most people will be your most concentrated and hence the most valuable. Maria, next slide. Thank you. So we've been doing our program for a long time. Definitely when you start a patient drug testing, you want to decide in advance, how are you going to give them the results? Who's going to get the results? You know, ideally the patient and the parent would be getting the results, and you would have this triangle where there's sharing of results. The way we've always done it is if a patient has an unexpected drug test result, something we're not expecting, then it says they would come in for an in-person visit. More recently, this has been a virtual visit. And then, for example, in a patient, Maria's patient who's using cannabis regularly, if we were to get a really unexpected drug test result, let's say cocaine or fentanyl or something like that, then the parent gets an emergency phone call from the physician on call because there's a safety issue of that. Maria, next slide. So we have a tip sheet for drug testing, and the next few slides are just so that I could make sure to hit everything covered in the tip sheet, which I think is a really valuable resource. So you're deciding, you're talking to your patient and their parent about drug testing. You have a few decisions to make. Will the testing be done at home or in the lab? You definitely want to make sure before the first test is obtained, who's going to get the results. The patient can't change the rules once the test comes back and say, well, you can't tell my parents. And then how are you going to share the result? So we talk to parents a lot about a behavioral contract, which is, setting a list of expectations around the adolescent's use. And this works very well with drug testing. So I like the example in the tip sheet. So let's say a patient agrees to start drug testing, and they're motivated to change their use. So they have a negative test, they get a thumbs up, they can go out with friends, they have a curt view. You want to give them more rewards if they have a series of negative tests. Second test is negative, parents can extend the curt view. We are very strict about driving and cannabis use, and I appreciate Maria's example. We will tell parents that if their child is using cannabis regularly, their child should not be driving. We're very black and white about this because it's a safety issue. And so we routinely tell parents that a child has to drug test and has to have 3 negative tests before they should be allowed to drive. Not every parent follows through, but they always hear us give that advice. Meanwhile, if there's a positive test, that's a step back, and then there would be a negative consequence, or you would start at the beginning again until there's a negative test. And again, positive means there is a substance, negative means substance-free. Maria, next slide. Thank you. So this is a pretty dry slide. The point is, if you'd like to start drug testing, and if you have access to Quest, we have an order set that we will give you, which is what we test for. So anyway, that is just information that we would love to share with you. I've sometimes fielded questions about other labs, and a lot of it is just translation. I can certainly help you figure out what your panel should be with the lab that you're working with, meaning that's a very appropriate MCPAP call. Next slide, Maria. All right, so if the parent is collecting a specimen at home, you want to go over certain ground rules to make sure that there isn't an opportunity to manipulate the test. You do want a concentrated test. If you Google beta drug test, one of the first things that comes up is to submit a dilute sample. And so ideally the parent would be collecting the first morning urine, because typically that's going to be the most concentrated. The gold standard would be to have a parent in the bathroom when the child voids. I will say that for a lot of adolescents, that's a no-go for privacy issues. And I usually say it should be a same-sex parent if that's possible in the home. We are flexible. I think if the adolescent is saying, I'm not going to pee with my parent in the room, then what we would do is we would ask a parent to stay right outside the room. The door should be open so you're listening. Because there are, this could be a talk for another day, but there are ways to try to cheat if you don't have a protocol in place. So the most important thing would be the adolescent is voiding, and then the parent is right outside the door. As soon as they finish voiding, they don't wash their hands. They hand the sample to a parent. Urine should be body temperature immediately after voiding. And a lot of our Quest cups have a temperature strip so the parent can verify that it's appropriate temperature. And then the parent would take the specimen to the lab at their convenience. We always think about chain of custody. The parent should be aware of where they're leaving that urine sample before they bring it to Quest. Okay, I think I've covered everything. Oh, the one pearl that I love to give is if a parent is doing random weekly testing, there are some patients who will try to beat the system by using the day after the test because they figure they have the longest window. And so it's good advice to tell parents every now and then to collect 2 tests in the same week to see if that's taking place. Maria, next slide, please. So this is a little cheat sheet about interpreting results. You want to make sure that you're getting an adequately concentrated specimen. There's something called the random urine creatinine, which is a marker of concentration, and you want to make sure that is above 50, which is adequate concentration. In a moment, we're going to talk more about monitoring THC levels, which Maria highlighted in her case. Alcohol, we test for alcohol metabolites. You may know that ethanol is very fleeting in the urine, so we look for ethyl glucuronide and ethyl succinate. Generally, you have about a 3-day window after someone consumes alcohol. Sometimes for very low levels, you have to worry about incidental exposure, just something to keep in mind. We do test for cotinine. We're talking about all of our patients with vaping, and that is the metabolite for nicotine that you can see in the urine similarly for about 3 to 5 days after use. I will caution you that if you are giving nicotine replacement therapy, it's a waste of money to look for the cotinine because you will only see the replacement. So you won't necessarily know how to interpret that for a patient using NRT. Maria, next slide. So this is kind of urine drug testing advanced. This is the advanced version. There are some medications that can give false positives. So if you're doing a test for benzodiazepine for patients who are on sertraline, that's going to give you a false positive result, but the confirmatory test would be negative. So again, we welcome any call related to drug testing if you have a result that you're having trouble interpreting. For opiates, any Seinfeld fans, it is true that if a patient eats poppy seeds, they are going to have a urine drug test positive for opiates. And so, you would need to distinguish between that and heroin use, but usually you can tell by the context. Maria, next slide. All right, so one of the values of doing serial, not breakfast cereal, but SCR-IAL testing for patients who are using cannabis is in our testing, we are able to generate a quantitative value. And for patients who may not be willing to stop, you can incentivize to at least cut back on their use so we could see these levels drop. The way we calculate it is you get a raw THC value, you divide it by the creatinine, and then multiply by 100. I'm going to show you an example. And then I've developed this after years of being in the trenches. Generally, patients whose THC levels fall below 100 are in the low range. 100 to 1,000, I know that's a broad curve. Those are your moderate cannabis users. And then the kids who are using a dab pen, the high concentrated devices typically get THC levels in the 4 digits. Next slide, Maria. So this is an example. This is what a Quest drug test looks like. Look at the marijuana metabolite, which is in red, 1778. So if I want to get a value that I could compare from test to test, I take that number, I divide it by the creatinine, which is about 200, and that gives me a level of 931, which you can see is towards the upper limit of the moderate range. And that's something that a patient who's testing weekly, I could say to them, hey, how about you try to get that level below 700? Let's see how you do. Next slide, Maria, possibly the last slide. Okay, so this is a patient using very high levels of marijuana. You could see that the metabolite is greater than 5,000. So this is probably someone using a vaping device multiple times a day. Next slide, Maria. So this is an example of a patient who was in ASAP. Parents were working with us as well. He was told that he couldn't drive until he stopped using marijuana. And so they did a series of weekly urine drug tests. And I'd call your attention to the second half of the screen where you can see the THC level coming down. And then after January 15th, we thought that was probably just vestigial. And so he was given the car keys back. But this really works with certain patients, the idea of monitoring their THC levels. All right, I'm going to give it back to you, Maria.
Okay, great. The next case vignette that I'll be talking about is Lily. Lily is a 21-year-old Latina female who was referred to substance use counseling by her PCP due to that reporting that she was using inhalants. She was huffing rubbing alcohol. Lily reported that she has been inhaling rubbing alcohol several times a day for the past couple of years. She states that her body craves rubbing alcohol and that there are times where she will go through a bottle of rubbing alcohol in a few days. She expressed that she wants to stop because she is worried about the long-term impact of inhaling the fumes on her brain and her body. Lily states that there was a time where she didn't have access to rubbing alcohol when she tried to stop, but that she started inhaling acetone at the factory where she worked at, and she eventually returned to using rubbing alcohol again. She states that she drinks socially with friends, but denies any other substance use. Currently, Lily has a full-time job and reports functioning well in her job. She reports that she was emotionally abused by her mother as a child, and she remembers her father being very strict, but he also could be very caring and loving. Last year, her father suffered from a significant medical issue that led to her moving. She was living on her own at the time, but then she had to move back home with her father and her brother, who was 18, to help care for her father. Lily reports having experienced both depression and anxiety in the past as well, and has tried therapy before, but has had trouble sticking with it. My initial treatment with Lily has focused on her main goal of wanting to reduce her use of rubbing alcohol. Due to her unwillingness to abstain completely, my strategy focuses on reducing harms associated with inhalant use and motivational interviewing to increase willingness to make behavior change. As with many, if not all, my patients go back and forth. So Lily will sometimes say she wants to stop, and then sometimes, there are other days where she doesn't want to stop at all, or she wants to just reduce it. Although abstinence is recommended, it is critical that we start where the patient is at. I've worked with her on monitoring her use in order to identify the patterns. We have focused on identifying replacement behaviors as well. And I've also worked with Lily on identifying thought processes that lead to her use and work towards examining more helpful thoughts. So if she's feeling really bad about herself, feels like she really needs a break, she will often resort to huffing rubbing alcohol. She, through this work, she's identified that when she's occupied with activities with others, when she's socializing or, has a certain specific task that she's working on with others, that she inhales it much less often. When she's stressed with work tasks, she finds herself using more and more, or she's stressed related to other events going on in her life with her family. We have focused on identifying the replacement behaviors, as well as also restricting her access to rubbing alcohol. A few months ago, she started leaving the rubbing alcohol at home so that she wouldn't use it as often instead of keeping inside her car. She drives for her work. She, is traveling a lot, to different places, so that it was a kind of easy access. However, we also, talk about how, this is something that's pretty easily accessible. She can go into any store that has hand sanitizer that could be of a high alcohol content, or she can go to the drugstore and buy rubbing alcohol. We regularly talk about how to manage these triggers and cravings. Through the course of her treatment, it becomes apparent that stress and emotional challenges in her life impact her use. She shares that she feels incredibly isolated and lonely because she doesn't have many close friends. And we have discussed different ways that she can seek out contact with others. Though it is really challenging for her because she also feels obligated to take care of her father. She feels the pressure. She talks often about the responsibility that she feels towards her father because he's depressed. She feels that she needs to, make him feel better. And she's been expressed frustration that he's rejected a lot of the supports that she has tried to offer him. She's tried to recommend going to counseling, but she's like, he never will, because he's very stubborn, trying to get other support from other family members. She does have a pretty large extended family, but a lot of times her father rejects that help. Through the course of our work, I focus on helping Lily work towards self-care and asking for help from others. I've used the analogy, that when we've been on an airplane, that you have to put the oxygen mask on yourself before you help anyone else. I think, this is, I try to, especially with this particular patient, trying to work on focusing on herself and telling her it's okay to focus on herself. Recently she was able to seek out support from other extended family members and feel comfortable moving out on her own with her brother, so that she, for her, it was important for her mental health. And then our work continues to explore ways that she can improve her self-esteem and self-confidence, while also developing healthier ways to cope with stress and anxiety. I've regularly collaborated with her PCP about her progress and have discussed different ways to support Lily. We have even discussed looking into getting her an evaluation with psychiatrists to see if there's a way to address her underlying anxiety symptoms, as well as we've also discussed the possibility of naltrexone as a way to treat her cravings, since she's been in therapy for a while and she's still really struggling with the cravings. Okay, sorry, next slide. Next, I'm going to talk about Michelle. Michelle is a 16-year-old Caucasian female who was referred by her PCP for substance use counseling due to concerns about her cannabis use. She was, she had had an episode of hyperemesis where she was vomiting related to her cannabis use, and they were concerned and wanted it to be addressed. Through counseling, Michelle has been able to share that she has been using cannabis and also has experimented with other substances as a way to cope with the challenges and many stressors that she experiences in her life. A common theme discussed in individual counseling sessions is that she feels, very isolated and alone and does not have many peers with whom she feels that she can connect with. So Michelle is an excellent candidate for a new virtual psychotherapy group that I'm going to be offering for high school students who use substances with ASAP MCPAT. The objectives of this new group is to support adolescents' journeys in discovering and or reconnecting to their beliefs, attitudes, and values about moving through life's stresses and adversity, including their relationship to substances. Together, we will strive to understand the function that substance use plays or has played in their lives. And it is also an important opportunity for them to get in touch with what they want in their lives and what they want for themselves, and to connect with others on the same journey. So what I will do in the next week or so is I will send out a handout that will kind of be describing what a little bit about, for providers, the group, which is a lot of information that is on these slides. So the main criteria for the group is that they would need to be an adolescent in high school who is using substances. And it's important to note that if they have active suicidal ideation, a recent suicide attempt, or are experiencing psychosis, including hallucinations, that they wouldn't benefit from virtual group therapy at this time. Also, it's important to note when you refer someone to group, it doesn't guarantee that they will benefit from group. Basically, when you make a referral, what we'll do is myself and the other group facilitator will do an evaluation with the patient and their family to assess their needs and discuss whether it's a good therapeutic fit. It's a little complex, getting groups together. We want to make sure that people feel connected, that there is some common bond, and that they will have the opportunity to connect with others. In this sheet that I will send out, there's a sample provider script. So basically, if you are thinking that the patient might be a good candidate, you would say, oh, we have a virtual psychotherapy group offered by a clinician at Boston Children's Hospital. If you are interested, I'd be happy to pass along your name to Maria, who runs the group. You'll receive a call from Boston Children's Hospital, the Primary Care Plus program, to set up an appointment to talk about it with her and to learn a little bit more about the group. And so to make a referral, it's similar to how you would make a referral for individual substance use counseling with MCPAT, the ASAP MCPAT program. You call your local MCPAT team and let them know that you want to speak with the ASAP consultant. And then when you speak with the consultant, you'd let them know specifically that you're making a referral for group. And then the ASAP consultant will ask you for this information, which is also information that they will ask you if you're referring for individual substance use counseling. So the age of the adolescent and the types of substances used, any concerns related to acute psychiatric issues, child protection issues, domestic violence that has been noted, just because we want to make sure that virtual care is appropriate for them. And then we'll want to know, is the family aware of the referral? Who is aware of the referral? Who is the primary contact person, as well as their name and contact information. We don't want any surprises when we call them. They're like, what? You referred me to a group? I don't know what you're talking about. So we just like to know that information ahead of time. And then what does the patient or family know about the reason for the referral? And then the contact information for the physician seeking consultation. Because sometimes we will touch base if it's something that you were planning on referring and you were going to reach out to the family, but you hadn't yet. We might check back with you or your staff just to double check before we reach out to the family, just to increase the chances that they'll be interested and not caught off guard. So that concludes our presentation. I'm going to open it up now for any questions related to any of the material that Dr. Schezer and I went over. You can enter those questions into the chat.
Yeah, actually, at this point,
have we gone? Oh, we're almost done.
No, you're good. We still have a few more minutes, but at this point, if you have a question, feel free to just use the hand raise function, and then we can unmute you, and just so we can sort of talk to each other a little bit now, so we don't screen them. Yeah. I'm
going to stop the share just if that makes sense, so that I can see. So it's not just my screen that you're seeing.
Yeah, so I don't see any questions in the chat. And so let's just give people a moment to sort of consider if they have any questions. I really hope that our pediatric primary providers, oh, good. Yeah, we'll refer patients to the ASAP program. So Brooke, are you unmuted? Can you talk now?
I think so. Can you hear me?
Yes, perfect.
We can hear you.
I'm curious, the ASAP program, I think I'm remembering this correctly. Is it a voluntary program for teens?
Oh, should I start, Maria?
Yeah, you can start.
You know, I would have to say that it's voluntary in quotes. You know, one of the things I like best about our program is that we're family-based. And so typically we will see an adolescent or young adult coming with a parent. You know, a lot of the adolescents don't think they have a problem. They don't really want to have anything to do with us, but there's some leverage in the background where the parent is worried and they are insisting that their child come to see us. And then, of course, what we start to do is we try to build a therapeutic alliance and convince the patient that there's a good aspect to being there. Anyway, long answer to a short question. So I would say voluntary in quotes would be my answer.
Yes. And I think, you know, particularly if a patient's not interested in engaging, sometimes I will start with just meeting with the parents, because I think the parents need a lot of support. And, you know, and they're feeling overwhelmed and it's very emotional, and, you know, kind of talking about some behavioral management strategies, or even sometimes just, you know, to support them. So, and then sometimes the adolescents come around or sometimes something happens that, you know, the parent wants to, you know, says that you need to participate in counseling in order to, you know, gain a certain privilege because they want them to be talking to someone.
And I just want to say, I just want to jump in that some patients are happy to come. Some patients want to come. So I don't want to make it sound like everybody is being dragged. I think our patients are really a broad spectrum of intrinsic motivation and coming because their parents insist.
Mm-hmm.
And then for clients who might need a higher level of care, above you guys, if you assess that there, can you make referrals from there,
Yes,
like to a
definitely.
detox?
Yeah, so with patients that I've worked with, I mean, so sometimes even just doing the evaluation, I mean, typically it doesn't happen, but sometimes doing the evaluation, it may become apparent that the patient might need a referral to a partial program, or they might benefit from residential, you know, or if that happens over the course of treatment, I can assist with making referrals. I've done that before.
Thank you.
Thanks.
Thank you.
All right, well, it looks like there are no other questions. If people have questions that they think of later, feel free to email them to us, and we can forward them to the presenters and try to get answers for you. But this brings us to the end of our time, and thank you so much, Maria and Dr. Schizer, because this was a really, really useful presentation. And I would just ask everybody to give us feedback, because if you ask for CME credits, you will get a link to when we figure out how to work the system to send you an evaluation, so you can get your credit. And so we will read very carefully all of your feedback. And if you're not requesting CME, then you'll have a pop-up when you finish to ask for some feedback. So just save the date. February 22nd is our next program. And thank you so much for joining us.
Thanks for having us.
Thank you for having